So, hi friends, today we'll be discussing infection control in oral and maxillofacial surgery. I'm Dr. Abhinn Miglani, Department of Oral and Maxillofacial Surgery. So, why infection control? So, it helps in prevention of surgical site infection, improves healing, prevents complications, ensures longevity of grafts and implants. And what are the common sources of infection? The endogenous oral flora, contaminated instruments or gloves, poor surgical hygiene, patients' poor compliance. What are the endogenous sources? Oral flora, skin microbes, patients' systemic diseases, and the exogenous sources, surgical instruments, airborne pathogens, OT personnel. Pre-operative evaluation. So we have to take a thorough history and systemic screening, detect diabetes and any immune issues, rule out local infections, advise pre-op hygiene. Lab investigations, we require CBC, blood glucose, C-reactive protein and other inflammatory markers. Pre-operative hygiene. So we will be prescribing chlorhexidine gluconate mouth rinse, specifically 0.12% to 0.2%, which reduces the microbial load, given twice daily for 2 days pre-op and 15 to 30 minutes before surgery. Professional scaling and oral prophylaxis for elective cases like orthognathic surgeries or tumor surgeries. And we need to remove the calculus, caries, and periodontitis and rule out any other dental issues which might hamper with the post-operative healing. Treatment of local infections, drain abscesses, or treat active infections like pulpal, periapical, or periodontal issues before the surgery. Pre-operative hygiene, pre-operative bath with antiseptic soap like chlorhexidine 4% and betadine to be done the night before and morning of surgery to reduce skin flora. Hair removal if needed, use electric clippers, not razors, to prevent microabrasion. Facial hair management, beards and mustaches may need trimming in cases like facelifts or neck dissection to allow better adhesion of drapes or dressings. So these are the antiseptic soaps which can be used: chlorhexidine, hydrochloride soap, collidine, betadine soap, hair clipper. We can see a hair clipper here which prevents the microabrasion which might be caused by the razors which are conventionally used. So the key differences between an antiseptic, antibacterial and disinfectants are here. So the property, that is the target microorganisms. Antiseptic will be acting more commonly on the broad spectrum, the bacteria, viruses, fungi. Antibacterial specific to bacteria, and disinfectants are broad spectrum, majorly acting upon bacteria, viruses and fungi. Application: antiseptics act upon living tissues, skin, mucous membranes. Antibacterials too on living tissues like skin, mucous membranes. And disinfectants are usually used for inanimate surfaces, for example floors and countertops. The main function of antiseptic is to prevent infection. Antibacterial's main function is to kill the bacteria or inhibit their growth. Disinfectants kill or deactivate microorganisms or surfaces. Then coming to examples, like antiseptics include alcohol, iodine, hydrogen peroxide. The antibacterials consist of antibacterial soap, Neosporin, and disinfectants consist of bleach, disinfectant sprays, hydrogen peroxide based cleaners. And antiseptics are usually used in wound cleaning and hand sanitizing. Antibacterials are used more commonly in treating bacterial skin infections. Disinfectants are used for cleaning surfaces, sanitizing equipments. So, can I use an antiseptic on surfaces? While antiseptics are meant for skin use, they can be used on some surfaces in a pinch, but they are not as effective or efficient as disinfectants for cleaning. Are antibacterial soaps better than regular soap? Antibacterial soaps may be more effective at killing bacteria, but regular soap and water is still sufficient for cleaning hands effectively, especially if used with good hand washing technique. Is bleach a disinfectant or an antibacterial? Bleach is a disinfectant. It kills a broad range of microorganisms, including bacteria and viruses. Can I use disinfectants on my skin? No, disinfectants are designed for surfaces, not for use on skin. Always use antiseptics or antibacterial products for skin care. The optimal time to apply an antiseptic solution prior to a surgery is typically a few minutes before the incision. allowing sufficient contact time for the solution to kill bacteria on the skin. Specifically, many protocols recommend allowing the antiseptic to dry on the skin for a minimum of 2 minutes before surgery, especially when using solutions like chlorhexidine gluconate. Other guidelines suggest a drying time of 10 minutes for povidone iodine, as some bacteria may be significantly reduced after this drying period. So the some common examples of the disinfectants used are household bleach, quaternary ammonium compounds, hydrogen peroxide, formaldehyde, glutaraldehyde, alcohol. Some examples of common antiseptics include chlorhexidine, povidone iodine solution, chlorxylenol, hand sanitizer. Preoperative hygiene, nasal and throat decontamination. Intranasal mupirocin, especially in MRSA carriers, and applied 2 to 3 times daily for 5 pre-op in high-risk patients or hospital-acquired infection units. Oral decontamination with povidone iodine gargle or betadine lozenges, especially before airway or oropharyngeal procedures. Risk factors. So we need to screen for diabetes, anemia, immunosuppression, poor oral hygiene. So proper history need to be taken before doing the preoperative preparation. We need to do with oral rinse of chlorhexidine or antiseptic skin scrub, hair trimming if required, antibiotic prophylaxis, instrument sterilization, use autoclaves with validation indicators, separate kits for each surgery, disposable where feasible, sterilization cycle monitoring, mechanical indicators like time, temperature, pressure logs, chemical indicators, color changing strips on every pouch, and biological indicators, spore tests weekly for autoclaves. Types of autoclave indicators. The class 1 indicators are the simple indicators, class 2 indicators specific indicators, class 3 indicators which monitor the chemical sterilization process commonly used with ethylene oxide and hydrogen peroxide sterilization. Class 4 indicators include monitor the time and temperature clinical parameters of the sterilization process but do not include spores. I hope everyone is having a notebook with them. Kindly note these points. Class 5 indicators provide real-time monitoring of all critical parameters of the sterilization cycle. Class 6 indicators, the emulating indicators used for pack monitoring and confirm the presence or absence of specific time and temperature parameters. The Bowie Dickey tape, a specialized type of indicator used to monitor the performance of vacuum-assisted sterilizers. Biological indicators include these indicators typically spore strips or vials contain resistant bacterial spores like Geobacillus stereothermophilus. After autoclaving, the spores are incubated, and if growth is detected, it indicates that the sterilization cycle failed to kill the microorganisms. Incubation is typically done at 60 degrees Celsius for 24 hours. So these are the methods of sterilization. The autoclaving, steam for heat and moisture resistant instruments, 121 degrees Celsius for 15 psi for 15 to 30 minutes. Dry heat for sharp instruments, metal trays, 160 degrees Celsius for 2 hours. Chemical sterilants, heat sensitive tools, for example endoscopes, are used with glutaraldehyde for 8 to 10 hours. Ethylene oxide gas, plastic devices, implants, 50 to 60 degrees Celsius, 4 to 6 hours. Plasma sterilization, high-end equipment, heat-sensitive materials, less than 60 degrees Celsius with a short cycle. Storage of instruments. So they're stored in dry, dust-free and closed cabinets. Maintain first in, first out FIFO principle. So what is a FIFO principle? So the sterile set should be rotated in storage to ensure that the set which was sterilized the first gets used first. So the separate instruments, the principle of separate instruments, separate trays for intraoral and extraoral instruments to prevent contamination. Use disposable suction tips, suture packs and surgical drapes where feasible. Instruments exposed to bone, implants or sinuses should be sterilized with maximum assurance methods, for example class B autoclaves. For example, a contaminated periosteal elevator used in implant surgery should transfer Pseudomonas or Staphylococcus aureus, resulting in peri-implantitis or abscess formation leading to implant failure or osteomyelitis. Surgical team preparation, proper hand scrubbing for 7 minutes, sterile gloves, gowns, face shields, avoid unnecessary OT traffic, 5 to 7 minutes antiseptic scrub with chlorhexidine or iodine, and sterile gowns, gloves, masks, face shields. Avoid conversation and movement in OT. Change gloves during long procedures. So this is a video I found in the YouTube. These are the 7 steps of hand wash. So I hope you liked the video and understood the steps of hand washing and scrubbing. So surgical field preparation, skin preparation with povidone iodine or chlorhexidine. Apply antiseptics in concentric circles from incision site outwards. Draping to isolate sterile field. Minimal exposure of non-sterile areas. Aseptic surgical technique. Gentle tissue handling. Regular irrigation. Avoid excessive cautery to reduce necrosis. Sharp dissection and control bleeding. Suture under minimal tension. The zones of OT. The outer zone includes the rest of the hospital outside the theatre complex. Clean zone, theatre complex outside the operating area. Aseptic zone, the operating area. Disposal zone, separate exit for contaminated or used linen and instruments. Infection control and extractions. Treat infected molars with caution, curettage and irrigation. Post op antibiotic if needed. Avoid leaving necrotic bone or root tips. Implant surgery protocol. Sterile kits and gloves. Avoid implant contamination. Avoid touching it and use of sterile forceps. Minimal manipulation of osteotomy site. So in TMJ orthognathic surgery, deep dissection needs advanced preparation. Use sterile plates and screws only. Trauma surgery considerations. Early debridement of wounds. Start antibiotics promptly. Monitor for signs of infection. Neck surgery protocols. Larger surfaces area demands broader asepsis. Drains should be properly positioned. Sterile dressing and suction management. Hair transplant procedures. FUE and FUT create multiple punctures. High risk of infection due to the exposure. Requires careful sterile execution. Pre-op antiseptic shampoo with chlorhexidine is required. Sterile punches, forceps, implanters. Topical and systemic antibiotics postoperatively. Postoperative care. Patient is advised on wound care. Avoid moisture or sweat on wounds. Maintain dressing integrity. Postoperative medications. Antibiotics based on risk stratification. NSAIDs and antiseptic mouthwashes. Skin creams or ointments for external wounds. Signs of infection. Swelling, redness or pain at site, fever or foul smelling discharge, delayed wound healing. Managing post operative infections. Early diagnosis is critical. Incision and drainage if needed. Culture sensitivity testing before antibiotics. Immunocompromised patients includes cancer, transplant and controlled diabetics. Require stricter infection controls. IV antibiotics and hospital settings recommended. Antibiotic stewardship. So it avoids empirical overuse, use narrow spectrum unless indicated, complete the prescribed dose. So antibiotic stewardship refers to efforts in doctors' offices, hospitals, long-term care facilities and other healthcare settings to ensure that antibiotics are used only when necessary and appropriate. That means prescribing the right drug at the right dose at the right time for the right duration, supporting an interdisciplinary approach, enhancing infection prevention and control, controlling the source of infection, prescribing antibiotics when they are truly needed, prescribing appropriate antibiotics with adequate dosage, using the shortest duration of antibiotics based on evidence, reaccessing the treatment when culture results are available, and supporting surveillance of AMR HAIs when, and monitoring of antibiotic in the consumption and educating staff. Then antibiotic prophylaxis, the pre-operative antibiotics, the timing, administer antibiotics 30 to 60 minutes before the incision to ensure peak plasma and tissue levels. For oral antibiotics, administer 1 hour before surgery. If delayed beyond 2 hours from administration to incision, redose may be needed. Antibiotic prophylaxis. So indications are the clean contaminated procedures. Most OMFS and head and neck surgeries fall in this category. Intraoral incisions, mucosal communication, contaminated or dirty procedures. The fractures exposed to the oral cavity, infected cyst and abscess drainage. Use of foreign materials, plates, screws, TMJ processes, implants. Patient-related risks include immunosuppression, diabetes, valvular heart disease, history of surgical site infection. So the antibiotic selection in mild to moderate oral and maxillofacial surgery, 2 gram of amoxicillin per oral or ampicillin 2 gram IV, or alternatively clindamycin 600 mg per oral or IV or azithromycin. You can note this criteria. Special pre-op scenarios in endocarditis prophylaxis, we use amoxicillin 2 gram per oral 1 hour before or clindamycin 600 mg per oral. Free flap or microvascular surgery, start with broad spectrum IV antibiotics, continue post-operatively for 48 to 72 hours. Trauma with open fractures or intraoral communication, empiric coverage for oral flora and skin flora, for example, amoxicillin, clavulanate, clindamycin. Antibiotic therapy. Post-operative antibiotics. General guidelines include uncomplicated, clean cases, for example, minor extractions, no antibiotics post-op. Clean contaminated surgeries include post-op coverage for 24 hours to 5 days depending on extent of tissue dissection. Duration of surgery, more than 2 hours increases surgical site infection risk. Use of implants or grafts, patient comorbidities. So antibiotic therapies, for the duration you can note these for, or if we use 3 to 5 days, head and neck with mucosal entry for 24 to 48 hours IV, then implants and TMJ prosthesis 5 to 7 days. Common post-op antibiotic regimens include oral amoxicillin for 500 mg, TID for 5 days, and rest you can note down. Operation theatre protocols, HEPA filtration or laminar flow, scheduled disinfection routines, restricted entry policy during surgery, high efficiency particulate air filter. So the documentation, maintain OT infection control, record sterilization cycles and expiry of packs, and report and investigate every breach. Advances in infection control, use of UV sterilization, antimicrobial sutures and gloves, and AI for predicting infection risk. So these are some articles you can check for more depth knowledge of AI in infection control. Then this is one another article, antimicrobial sutures for prevention of surgical site infections. Thank you for listening.